just signing in so we can get credit, because they give us credit for our group. It's called the Virginia Vascular Study Group.
Oh, cool.
So my partners and her, as long as we can sign in, then we get a credit. And eventually, they give us, we do all these things so we can receive a star.
Oh, nice.
so we have to be part of the meeting.
All right, can you hear us, everybody?
I can hear you, Betsy.
Yes.
Okay, perfect. And we can hear them now. Okay, perfect.
Do we need to be louder, or are you guys good?
That seems like good.
Sounds good.
We have we have the video up on our main screen, so anybody that is willing to go turn their video on so we can see your shiny, happy faces, we'd love it.
We're sharing ours.
We're sharing ours.
Come on. All right, thank you all for being here. And thank you for our wonderful IT people that were coming in. So thank you. Sorry about that. We just had a little technical difficulties here. So welcome. Today's Thursday, April 28th, and we're here for the Virginia Vascular Study Group. Dr. Mintz is here with us, and Dr. Musa is here on the phone with us. So welcome, everybody. So before we get started, just want to make sure, thank you all for signing in. And also for those that are on the phone, make sure you're going to get your credit. So make sure instead of signing in as guests, make sure you sign in with your full name. And if you have a full room, wherever you are, make sure you reach out to Leka Johnson, ljohnson@svspso.org, and give her everyone's full name and center wherever you're from. And she will make sure that you get the points. So again, make sure you sign in with your name. If you need help signing in or renaming yourself, just type into the chat and Jen Correa will help you do that. So let's get started. Just want to do an appreciation and thank you to Dr. Musa and Dr. Mintz for hosting this regional meeting, Stacy and also Rochelle. They're our regional lead data managers. Dr. Marini is our associate medical director. Christopher Huffman is our director of analytics and analytic team. Jen Correa is our SBS PSO marketing manager. And again, she's also helping us behind the scenes today. Myself, I'm Betsy Weimer. I'm the SBS PSO Director of Quality, and also our other behind the scenes SBS PSO staff that aren't here today. Just as a reminder, please routinely review your center characteristics for accuracy. You know, some people come and go, and just as a reminder, make sure you change their status to inactive and maintain their current email addresses. Here's our agenda for today. We've already had our data manager and our EC meeting this morning. That was from 11 to 12. And now we're going to do our VQI national updates. We're going to have council updates. Then we're going to do the VVSG regional data review. We'll have a short break. We'll do VVSG QI presentations. We'll have regional QI discussions. And then closing remarks, meeting evaluation, and adjournment. There's no disclosures today. And we want to welcome, we have 3 new centers here. We have Berkeley Medical Center, Carilion New River Valley Medical Center, and Raleigh General Hospital. So we want to give a shout out to all the new centers. And now we're going to get started with our national VQI update. So for the spring of 2022, we just kind of wanted to give a refresher of what is a PSO. So PSO is a patient safety organization. It was actually created under the authorization of the Patient Safety and Quality Improvement Act of 2005, which is also PSQIA. That's a mouthful. Our goal is to improve the quality and safety of healthcare delivery. So the PSQIA encourages voluntary reporting and sharing of patient safety information without the fear of any legal discovery. The functions of a PSO: we protect comparative data from discovery. We eliminate the need for patient consent and IRB approval for core registry participation. We allow patient identifiers to be included for internal purposes, and only de-identified data can be released. This includes benchmarking, risk-adjusted adjustment, and merging with other identified data sets done within the PSO. QI research requires approval of the PSO RAC committee. Analytic data sets are de-identified. Some of the PSO activities are Patient Safety Work Product, PSWP. These are reports that identify center-specific or physician-specific outcomes or processes. So for the VQI, those are our semi-annual reports, our quarterly dashboards, and our COPI and CAPI reports. All reports are treated as confidential, and the utilization of the PSWP encourages a culture of safety, provides a mechanism for feedback, and is non-identifiable. And most importantly, it is never used for punitive or competitive purposes. If I choke up here, there's a fly up here. So I apologize if I swat. Patient Safety Evaluation System. So these are the center requirements, the PSES. We have designation of user account privileges. The PSWP analysis is recommended to be outside of normal QA peer review meetings. They develop a process on how to integrate PSWP results into the overall QI operations. And the PSES requires training for those with access to PSWP to ensure that the privilege and confidentiality of the PSWP is maintained. The law provides significant penalties for failure to maintain the confidentiality of the PSWP. Now moving on, we currently have 928 VQI centers. We are thrilled to have that. That includes one center in Singapore. We have 18 regional quality groups. And currently we have 936,887 procedures captured. The top is within the PVI registry, and second is in our carotid endarterectomy registry. VQI VAM 2022 is upon us, and we're so excited. It'll be here before we know it. So June 14th and 15th, it starts off. On the 14th, it starts at 12 noon, and our poster reception is from 5 to 6:30 p.m. I'm thrilled to share with you, we have 19 posters this year, and I am so happy. They are wonderful, great topics, and I look forward to networking with everybody. 3 of the posters are authored by our FIT trainees this year. So I'm excited to share those too. Wednesday is a full day from 8 a.m. until 5 p.m. And we are in Boston, Massachusetts. So we hope to see everybody there. You can't tell I'm excited, can you? Long-term follow-up reporting. So currently we have those reports available for EVAR, carotid artery stenting, and carotid endarterectomy. But soon to be released, they're coming for PVI, TVAR, IVC, and HDA. So coming soon. Device assist and Symmetric integration. This is something that's coming soon. It's actually quite exciting also. So Device Assist is actually a new device search functionality within Pathways that's going to assist you in finding devices used for treatment. You can search by device name, by manufacturer, and again, remember it's only in the PVI registry data collection tool. And then Symmetric is the actual healthcare supply software company. And this will help reduce or eliminate data discrepancies and provide real-time, up-to-date access to the FDA-approved devices. So, Chris, this is what you were asking about earlier. MyPad Pro. So this is a peripheral arterial disease pilot for quality of life survey, only for the PVI registry. This pilot has been extended for new interested centers. So it's a startup education and promotional documents can be provided to you. And if you're interested in joining this pilot, Danny Burgess is in charge of this, and you can contact Carolyn Morgan at cmorgan@svspsa.org. Again, the pilot has been extended for the MyPad Pro. Grants and industry meeting. This is just a topic that Lika Johnson wanted us to share with you. If you are looking for a grant for such as your regional meeting, she just wants everyone to be reminded that these are not guaranteed funds. On average, industry supporters provide about $1,000 to $2,000 for regional meetings. New reporting standards have changed the food and beverage support. So be prepared to cover those type of costs with other funding. And if you have any questions, please feel free to reach out to Leka Johnson, and she is at ljohnson@spspso.org. Coming soon, we're getting a new website. We're thrilled about that. VQI.org, new experience is coming. You're going to see a new look, feel, just fresh content and improved navigation. And this is going to be showcased at VQI at VAM. VQI also has a LinkedIn page now, so make sure you go out there and check us out and join our group. Also coming on the heels of our new website revamp, we're going to be having a VQI mobile app. This will be after our website design, so more to come for there. Dr. Jens Jorgensen attended an FDA 2-day meeting in regards to the endologic endovascular graft system and real-world surveillance of the AAA endovascular stent grafts. In conclusion, they released, there was a history of increased type 3 endoleaks, and so they spent follow-up for 5 to 10 years, and they realized that it needed more support. VQI provided data for this research. And so the VQI analysis of the paclitaxel controversy, there was a delta and a vision. One was delta was the registry surveillance, and then the vision was the VQI CMS claims matched analysis. In conclusion, they found that the prospective active surveillance of the SBS VQI PVI registry using a delta did not demonstrate a signal for increased mortality. And the claims analysis through vision did not demonstrate a signal for increased mortality or major amputation. VQI data did not show an increased mortality with paclitaxel devices either. Now we're going to move on to our QI update. So our trainee program. So we just began our trainee program last year. It was a pilot program. It's a mentor-based program. It's about 12 to 18 months long. Our trainees are encouraged to attend our regional meetings, review their center data, review with their mentor. They have quality and research opportunities. They can present VQI at BAM, such as the 3 that are presenting posters this year. They have a chance to be selected for a scholarship. They have quarterly check-ins with the SBS PSO staff, and we provide satisfaction surveys so we can gain feedback about the program. If you have any specific questions, you can contact either Dr. Gary Lemon or myself, or Bridget Smith also. So here's our 2022 or 2023 fit list. You can see our mentors, our trainees, and their centers, and we're super proud of this list.
Vascular, yeah.
So our, the program update is you can sign up to be a mentor at any time. And our next trainee application will be in January of 2023. So make sure you check vqi.org frequently. There's a tab for mentors and a tab for trainees. And you can share your tweets at #NextGenVQI. Next is our participation awards. So the 2022 Participation Awards program has the same 4 domains. Nothing has changed this year from 2021. Domain 1 is long-term follow-up. Domain 2 is regional meeting attendance. Domain 3 is QI project. Domain 4 is registry subscription. You can find this on vqi.org. The only thing that we did change is just a little verbiage under the QI project domain. And you can see where the red arrow is when you present a QI project. The only thing we ask when presenting a succinct regional meetings, your project slides must reflect a change in status. I'll give you an example. State use project.
The Navy guys are pretty good. I worked with Henry yesterday.
If we can have people mute themselves, that would be great.
And they've really enjoyed being here. They're getting to do a lot of
Yeah,
stuff.
Carnival didn't do a
So
fucking
Jim,
thing.
can you mute people?
Betsy, if you can hear me, this is Jen. If you want to make me a co-host, I can help with muting.
Absolutely. That might help.
I hope I'm muted.
Just tell them.
Yeah.
There we go.
I'll go ahead and make Jen a co-host too. She is. There you go, Jen. Sorry about that. But as an example for the succinct regional meetings, I'll use Stacy as an example. She's going to be giving a talk on her hashtag AAA project. And so it has been ongoing for a couple of years. And so I know she gave an update in the fall, and she's going to give one today for our spring regional meeting. And so I just asked that her slides have just a change, that's all, instead of presenting the same slides from last fall. That is simply the only change. So I just met my 1-year mark with VQI. I'm thrilled about that. So I wanted to take a little deeper dive into our charter history. And so I looked at the charters from 2018 through 2021. And first of all, I want to say congratulations to everyone. We had 74 charters last year. So kudos to everyone that did those. And those were data managers, physicians that did those. So I was completely just impressed with everyone. Also, in looking at through the years, I broke it down between long-term follow-up, DC meds, documentation, clinical, and other. And you can see those on the left-hand side of the screen. And other actually represents, it could have been a blend of the charter or something completely different. So anyway, so that I just kind of broke that down into those topics. But again, we had 74 last year, so kudos to everybody. And as of yesterday, we already had 22 charters presented and approved for this year. So, and it's only April 28th. So, you know, again, congratulations. So a lot of people have asked, how do I even begin a charter? I don't know what to do. So attend a charter focus call. Those are held quarterly. The next one is July 19th, 1 to 2 p.m. Eastern Time. Listen to prior webinars, review sample charters, and I have the links to both of those. Network with your colleagues, attend regional meetings, or if you don't want to do any of that and you just want to talk to me, you can. I'll do a one-on-one meeting with you. So just reach out to me at bweimer@svspso.org. Other things that I've been doing, I'm in my QI position. Again, the charter focus calls. There is a new format to register for those. Make sure you go to the vqi.org website and you register for those then. I hold a separate QI webinar quarterly. The next one is in July also. I assist Jen Correa with a monthly VQI newsletter. Again, I provide sample charters. And then you can see an overview of the QI tools by looking at this hyperlink. Again, to make sure you get CME CE credits, make sure you sign in. And also, Jen is going to put a hyperlink within the chat box a couple of times today. Make sure that you complete and submit the online form within 7 days. It's just 7 days from today. So make sure you do that because the link expires 7 days. And again, remember to PSO, put in your full name, send an email to Leka Johnson if you have more than 1 or 2 in your room, or you're having difficulty, or you just can't change your name or anything. And we'll go to the Arterial Quality Council. Is Dr. Tracy available to do her AQC slides? If you are, you can unmute yourself. If not, we'll go ahead and move ahead. So the spring 2022 AQC update, there was a discussion about the development of a new national quality initiative. The DC Med measure, everyone's doing great in it. We're about 86%, I believe, nationally across the board. And so we're thinking about putting that into maintenance mode due to the high compliance. We are looking at the EVAR sac diameter. There is a need for continued efforts to improve compliance. I think we're only like 62% in that area. So we need to continue with that. I actually did the National Long-Term Follow-Up Survey creation and results, and it looks like we still need to do some work also at the center level. It really does vary center to center. If you'd like to see those results or even take the survey again, I have those on vqi.org, and you can still take the survey. Our Christopher and his group are looking at VQI risk calculators, and more to come at that with at VQI at BAM. Harmonization of urgency variables are in the process of being included as much as possible across like registries. So that is a work in progress right now. The Venous Quality Council, I know Dr. Spinoza wasn't able to be with us today. So as many of you know, the SVS created a separate venous rack. They had 3 proposals in 2021, which is awesome. They had an AVF meeting February 23rd through the 26th of this year. And they don't have registry specific metrics right now, but they did discuss some ideas. So anticoagulation after venous stents, C2 disease for varicose veins, and IVC temporary filter retrieval. And if you have any ideas, feel free to reach out to Dr. Spinoza with those. And is Dr. Klaus available to speak for the arterial research?
Hi, it's Darren. I think hopefully it's all working. You can hear me.
Yes, absolutely.
Yeah, we had several projects that were approved through our region that went on for national data that are in various stages of presentation / reporting and publication. And I think I'll just leave it at that due to the length of the meeting, but I would say that if anyone in our region desires a project, either with regional data or national data, to please put through your templated VQI request, and our regional committee will review it. Just email it to me and I'll make sure that everybody gets the proposal, and we'll work through it and work with you to get approval. And if you want national data, to get approval through us to therefore then send your proposal for national data. Thank you.
Thank you so much. So you can see the top 10 publications. And also Dr. Maribi created videos on how to submit the RAC proposal for success. She's done useful tools and tips to train you and investigators. And then just to ensure your RAC submission is complete, there's data tables, full research proposal, your CV, regional RAC review, and just remember your center must participate in the registry related to your research proposal. And again, here's some hyperlinks for you. Review of list of the projects, the proposal online, and deadlines for submissions. And like Dr. Klaus said, make sure you can submit those to him. And then Dr. Musa, would you like to say anything for your governing council?
Hello, everyone, and happy VVSG spring meeting. So definitely, as we discuss it and to follow up on our last meeting, Dr. Lehman will be giving the updates. But we have some software development activities for the governing council will be related to the PSO for 22-23. And Dr. Jorgensen will be provide update on the FDA panel discussion for a project type 3 endoleak. And lastly will be Christopher Hoffman will be presented actually the PSO strategy around the development and the maintenance of risk calculators. But before also I just conclude here, I want to introduce to our meeting a significant, like my privilege and honor to have our president of SVS attending with us today, Dr. Ali Abramo, who is the chief in our section at the West Virginia University Charleston campus, and he was us over Zoom or over the teleconference as well.
Thank you, Albert.
Dr. Abraham, if you have any comment or any kind of like,
No, I
words.
admire you for keeping on this activities. I was very honored, me and Dr. Gib Upchurch, to start this initiative quite some time ago. And I'm glad the younger generation, you and the rest of the leadership, continue through this mission, because that's extremely important for the quality of vascular care. Thank you very much, Albert, and I'm very proud of all of you.
Thank you, Dr. Abraham. Betsy, you can take over.
All right, thank you so much.
You're welcome.
All right, and I'm going to turn it over to Dr. Mintz and Dr. Musa for the data review.
All right. Hi, everyone. So excited to see people. We have a couple people in person here. I'm just going to show you all of them. Hey guys, all right, we're here. So yeah, we're so delighted to have some in-person presence for this meeting. I'm gonna go through the data. I will say it's not tremendously excitingly new compared to the last couple of years. A lot of you are going to be familiar with it. We're going to go over it, make sure everybody knows what's up. But something we were talking about in the executive committee meeting was that we're really at kind of a point of Zoom fatigue. I'm sure you all can appreciate that. And some of the enthusiasm and energy that we had going with the VVSG 4 years ago when we came here last, a lot of that's kind of fallen away.
You have your truck by yourself?
What was that? Someone needs to mute themselves. But someone sounded excited, and that's what I'm going for. So anyways, we really want to try to kind of refine that excitement and everything else, and we'll talk some more about it today. I'm going to go through the quality report for the region. We're going to then have some presentations of some projects that have been getting done, and kind of we have some ideas from there of where we could talk as a region. How can we go forward to do a project together and maybe get people enthusiastic about working together again. So one thing, and I just want to say this now and I'll remind people later, but one idea that was generated from the EC meeting was that at least all of the physicians, any physician that is at a VQI center or wants to be in Virginia's, that is coming to VAM, we're going to have a meal together or a drink together or something. We got to get together. I know that everyone is going to try to go to VAM this year. So we got to get together and just meet with each other, see each other's faces again, and try to reestablish some of that enthusiasm. The other point of business is with regards to our fall meeting. We would very much like it to be at Winchester. Chris has volunteered. I think it's a great location and we would love to have it there if you'll have us. So ideally, we'd like that to be an in-person meeting. And unless there are people with very compelling reasons not to come in person, we would probably really try to focus on making that a in-person meeting. Okay, so let's go on to the quality report for the region. So any important updates? I didn't really find these to be too interesting, honestly. One thing that is interesting is that VQI now, the TransFem carotid stenting data is going to include patients with brachial and radial access also, which I think is a great idea. So that'll be in both the asymptomatic and symptomatic reports. That other part's not that interesting. Here's our dashboard. As you know, people didn't like the green and, and red, so we do coral and blue now. And coral is bottom 25th and blue is top 25th. And we're just going to go over our volume. So the procedural volume for our region, as you can see, we remain about 10% of all the data that happens in the VQI. Look at us, check it out. Southeast kind of got ahead of us, so I don't know what happened there. Northeast used to really dominate, but we have a lot of the data. Why is that important? Why am I telling you that? Because It's really easy to get regional data for the VVSG. It's a lot more work to get national VQI data. So if you want to write up a project, then it really is helpful to be able to easily get the regional data, and then you can build a project from there. I am going to ask him, what if he just, I'm going to give you my computer. Can you just monitor the chat room? I see it flashing. Thanks. Okay, I'm back. All right. Is there anything in the chat there that was important? Just let me know. I'll pause eventually.
No, Sam, I'm following this.
Okay, thank you, Albert.
Oh.
All right. So that's our procedure volume. So physician specialties. So this is the VQI, very boring. Vascular surgeons at the top. VVSG, what? Look at us. So we got a ton of different specialties. We're very unique that we have so many radiologists as part of our groups. And that gives us kind of a special flavor as far as the types of cases that are entered and how our data is presented. Going on to our regional data for long-term follow-up, you can see the differences in our long-term follow-up and the different types of procedures compared to the rest of the country. As you can see, we're doing very well overall. Our PVI follow-up is pretty impressive compared to the rest of the country. And you can see it's something that's actually really improved since 2017. And just so we're clear, the follow-up is procedures performed from January 1st to December 31st of 2019. And that's because you have from 9 months to 21 months to get all those patient data in. So that could really just be one of the reasons also that our follow-ups has improved. It's just that time elapsed. But one thing that we did do as a region was we unblinded the centers for follow-up, so everyone could see kind of who was doing really well and who was, have room for improvement. So you can see Winchester is kicking butt this time around. So I didn't know if maybe Chris, if you had any comments about presentation. She has a whole presentation about it. I knew that. Did I know that? I can't remember anymore. So we're going to present and talk about that. But I also just want to point out to Centera, because they have such a huge component of the VQI data for our region, and that's really over the last few years has really improved. If you had any comments you wanted to share, Heidi? I know. So if people couldn't hear from the audience, so our Centera team, they were really hurting for staffing during the pandemic initially, and they've really gotten up to speed. They've gotten a lot of staffing, and they just kind of put in their data, and more or less really has made our region look amazing. So, in Winchester, of course, but Centera has like 12 centers. You have 2 FTs. That's a lot of work. So they have 2 FTEs for all of their centers. That's impressive. So here we are. We are beating Canada, which has socialized medicine. So that's pretty impressive for long-term follow-up. So for discharge medications, so this is an area where we really have a very tight margin for error here, or a small, slim margin for error. So we are at 86% for VQI overall, region 84%. And look, it's tight, right? And we did really make a change between 2018 going forward, but you could see that, unfortunately, because this margin is so slim. Are you here for VQI? You can come on in. Come on in. Get some food and come on in. Oh boy. All right. We have someone else came. Great. So anyways, as you can see here, the margin for error is slim. So even though we're only about 2% off of the national VQI data, you could see that we're still significantly lower in our discharge antiplatelet statins. So just get on that. I mean, you don't have to discharge them with the medicines. You just have to have a reason if you're not. Does anyone have comments about that? Anyone noticing? I think we've gotten a little lax at our center, I would say. Maybe we fell off a little bit.
For our facility, we really applaud the local APPs. They do a lot of the discharging, and they have picked this up, and that is in like their regular DNA now.
All right. So yeah, that's something certainly our nurse, for us, our nurse practitioners and advanced providers, they all started, you know, we really train them to be on top of it because the residents kind of come and they go, but the people that are coordinating the care kind of stay. And so they are aware that it's necessary. Does anyone on the call have any comments about maybe how are they struggling with statin and aspirin on discharge for their patients? Anybody?
Oh, at WVU, that's the APP's goal. And one of their goals is to discharge appropriately.
Okay. Right. So that is a goal for our institution at WVU Morgantown.
We found it was an issue for our AMPs, and we investigated. We figured out that the hospitalists often discharge the AMPs, not the surgeons. So the APCs now are writing in their notes discharge on whatever medications they want them on. We've seen a tremendous increase in that.
All right. Albert, can you tell me, can you hear when people in the audience are talking, or do I need to?
Not really. I was about to comment this, and actually even the chat room. Yes, we're not hearing well when your audience in your room is talking to us. It's not like we're not hearing.
That's fine. I am repeating anything the audience says.
Sure.
So just Chris from Winchester just said that one thing they noticed was in the amputation module, and this is a good point. A lot of the time these patients are not discharged from the vascular service. They may be discharged from the hospitalist service. And so they've made a point of having their APPs actually write to in the discharge instructions or in their note that patients must be discharged on these medications. Anybody else? That's kind of really, that was the summary there, that the APPs are really essential in training them to make sure that they document and get it done. So onto the carotid data. So this is the transfemoral carotid stenting, asymptomatic stroke death rates. We're not significantly off of the national data here, so that's good. There is one center that has a higher level observed than expected. But when you kind of look here, there's about 159 cases being done by about 6 or 7 centers. So the margin for error is just quite slim in this patient population. So same thing with the symptomatics. Again, this is transfem. So you know, we go from asymptomatics being about 1% is the expected. And then for your symptomatics, less than 5% is what's expected. We've always ranged all of the carotid stent data, and the CEA data always tends to range a lot in the region. Sometimes we just have new centers coming online and they kind of skew the data. But you can kind of see here, we're still, so this reporting period, we happen to be looking okay. Again, there's only 4 centers that have more than 10 cases to be included in the data here. If anyone has a comment they want to say about that, that's fine, just interrupt me, I'm going to keep going. So for the TCAR patients, so here's stroke death for asymptomatic patients. And again, so here the margin is pretty slim. We're doing okay, we're still not significantly different. And again, it's just, you have a small margin. And sometimes, you know, I don't know, sometimes these TCAR patients, they're still sicker than your CEA patients, so that could be part of the problem as well. But so far, we're not significantly off. The symptomatic TCAR patients, so you know, Darren actually mentioned there may be some interesting data coming out from there. I don't know if you want to mention anything about that for the VAN meeting.
Oh, I was just noting that the top-rated abstract on carotid disease had to do with TCAR, the national data on TCAR in symptomatic patients, stroke treated within 2 weeks, showing that TCAR was slightly but significantly higher than CEA in that cohort. So that's an interesting abstract that's coming out nationally.
So stay tuned for that. So that's interesting data to consider. And it, you know, we have, again, some centers that are higher than others. And again, it can be a small number of cases though that kind of cause this issue, and the margin for error is pretty slim. For the asymptomatic patients, so we were significantly lower. Well, no, not significantly, but we were lower than the national average, but again, not significant. There's definitely a lot more centers doing asymptomatic. Oh, this is CEA. So we're doing well in that perspective. For symptomatic stroke, again, not hugely different. We do, again, have a pretty wide range. We have one center that is higher than the rest of the group. And I don't know if people want to talk about their experiences there or challenges with CEA in symptomatic patients at their institutions. I can certainly start by saying that at our institution, we do feel like we have very sick patients that are symptomatic, and that a lot of our, we looked at our actual ratio of patients, and we are like overwhelmingly symptomatic compared to asymptomatic for our carotids, which is not the case in most of the country. And we feel that that may be an actual public health issue in West Virginia, that people are maybe not getting screened. I don't know if Charleston, if you have the same breakdown of your carotid revascularization procedures, if you're doing more symptomatic than not symptomatic patients.
Like definitely just coming out of COVID, things were a little bit off during the COVID season because, you know, just for a lot of limitations, but majority we do electively are asymptomatic. Majority we do when we are on call are symptomatic. So the ratio, like, you know, we do average, I think 6 to 9 cases a week. And so it can be like, I would say 2/3 asymptomatic, 1/3 symptomatic kind of things. Or
Our
maybe even
ratio is different. Ours is more symptomatic, which we find unique in our population. And we just feel like maybe we're not screening enough. So for the asymptomatics then, we're again doing quite well. Look at that, look at us. Oh, this is the post-op length of stay, that's right. So post-op length of stay, we've written about it in manuscripts, it's been published. Our rural patients don't like to stay in the hospital, that's what we've learned. So they are more likely to get out quickly, and you could see we're significantly lower than the rest of the, like all of the VQI for a length of stay greater than a day. So that's good. So for symptomatics, that was for asymptomatics. For symptomatics, we're not significantly lower, but again, we're doing well. For EVAR, again, post-op length of stay greater than 2 days, we're fine in that area. Length of stay has not been a huge issue for our region. EVAR sac diameter reporting, so we're at 61.7%, so we're doing better than the rest of the VQI. So here's that data there. And again, we were part of the project to unblind the sac diameter reporting. And so you can see that, you know, certain centers, so Centera, Winchester are doing really well in that area. Lynchburg is not doing as well. I don't know if anyone's on the call from there that wants to talk about that at all, about the sac diameter reporting or any challenges that you may be facing in that area.
honestly, I think we've been monitoring this closely. So I'm just wondering if Regina Davis, which is one of our abstractors, available online to give us some feedback. Why I'm number 10 here.
I'm not really sure why we're number 10, except for the fact that, you know, when we did the EVAR charter, a lot of our patients were being done for other reasons, like saccular versus fusiform versus just other reasons, large growth, but we're falling behind in the actual numbers themselves. We'll do them at 4.9 instead of 5.5 because it increased X amount over the past 6 months. We also have some problems getting data from the residents. You know, we query them and it's like pulling teeth at times.
Okay, thanks for the input. Just we'll talk about it together, Regina, hopefully in next day or two. Samantha, carry on.
Yeah, so this is for follow-up sac diameter. So this is the report of the sac diameter at 9 to 21 months follow-up, not the sac diameter at time of repair. So that was because that was part of our follow-up reporting. But you guys are not, you know, you're significantly not different than third place.
Right.
We're just significantly different from first and second. Who are
what the problem was for our center this time for the follow-up data was a lot of our patients chose to not follow up, and so therefore either testing wasn't done, we did it by phone like televisit, or
hey, how are you?
We had to use a different visit, like they did come to see their cardiologist, but they didn't follow up with the vascular doctor. So, you know, that is improving. Our visits have gone up significantly, our follow-ups.
Huh.
I mean, I think if you do a telephone follow-up, that counts. You just have to document it.
That probably means that they think that they've got,
I think there's somebody that's
phlegmasia.
mute
So just make sure they're on heparin and bring them over, and then we usually ask the interventional radiologist.
Darren, I just text you.
All right. Moving forward. So again, we're doing well in our diameter reporting. Now, meeting diameter guidelines. So our region, we're not significantly different than the rest of the country on this one. We do have one outlier. I don't know who it is, but you know who you are. So there's one center that's really, I mean, they're only at 30% for meeting diameter guidelines for AAA repair. And that's kind of problematic. If anyone wants to speak to that, they're welcome to. If they would prefer not to, that's fine too. But that's, being at 30% is a little bit low. So T-bar sac diameter reporting, again, this was on follow-up. Again, we're doing well here. Our open AAA, so because the numbers are so low for open AAA, they've smushed them all together. So it's procedures performed between 2018 to 2021. So the dotted lines are our region's 4-year rate, and the solid lines are our current region's rate. So here we're looking at in-hospital death after AAA, open AAA. It looks like we've gone up a little bit, but as far as I know, we're not significantly different than the rest of the country. We do have one center that's higher than the rest. So again, using Cell Saver, we're fine. Making sure there's iliac inflow, we're fine. We're awesome at getting ABIs and claudicants, so please continue to be great in that. And I don't know if anyone has any comments. We always ask people if they can comment about that. You know, for us, we have a vascular lab integrated with our physicians, so they are getting their tests when they come to visit us, and that really helps. Anybody else have any comments about, you know, why we're doing so well with doing ABIs, making sure all our patients have a study before we do an angio on them? Okey-dokey. So major complications, again, no significant difference. This is suprainguinal bypass. Only 4 centers have enough cases to report. We're doing all right. Our amputation post-op complications, we kind of go all across the board on this one. I don't think we've ever figured out why that is. But again, doing all right. A dialysis using fistulas instead of grafts. We're doing significantly better than the VQI. I don't know if anyone has, I can pause here if anyone has any comments on the last two. Our IVC filter retrieval reporting. So that's an area where we've really gone up over the past several years. And again, that's part of the, I think that was part of kind of Centera's, I think it was the first time Syntera brought up to us that they were having an issue with staffing and trying to get a hold of all of these. And you were like, we followed up on all of these, we just don't have it in yet. And then you guys got it in, and then our numbers went whoop. So, you know, we just have to kind of keep up what we're doing there. We have about 67% that have had at least an attempt at a retrieval, 18% that are not clinically indicated to be retrieved, 2% the patient said no thank you, and others had later planned removals, and some that had no reason given. I think it's pretty good. Like, we've actually, our attempt rate is significantly higher, like 15% higher than the rest of the VQI. So that's great. And I don't know if it's because we have so many radiologists at part of our practice, because there's a lot of involvement with IVC filters and radiologists. And so I don't know if that's actually helped us. Before we used to say that it hurt us, but now it seems like it's the other way around. So any comments there? That's kind of the last piece.
I hope David Espinoza was us. He will always give us a very great insight when it comes to this every year when we discuss this issue about filter retrieval. But I think, honestly, I think in many institutions there's a very kind of like thorough follow-up system to track people who receive filter and to follow up on timing for retrieval or to keep them within guidelines. For our place here, the only caveat we have is most of the filters is done either for emergency situation or trauma situation, and we attempt diligently to get track of the people, and we always we're getting hard time to follow them up. We have this and the, you know, so, but I think it will definitely, there's some improvement of the region over. This is maybe one thing, Sam, I see some significant changes from all the slide you present before, because every slide before it's almost matching what we did in the last few meeting, but I think we're making some progress. I think better than before, at least.
Oh yeah, we are way better than before. I mean, and we just keep getting better here. So I will say, IVC filter retrieval. So at our institution, you know, Stacy led a charter on that, and one of the big moves was to create a share drive within Epic, where we could actually track. So there's a folder where you could track the filters that need to be retrieved, and so all the different departments that are involved in filters had access to that. It's like a running list. That was a kind of our big change. We had tried to like do a multidisciplinary meeting about the charter. I don't think we successfully met more than once. I can blame it on the pandemic, but we wanted to do both, but that didn't work out. But we still have had significant improvements. And again, you just have to get in touch with the patient for it to count. In the big picture, we want to actually take it out. And so that's, you know, that's a different issue with trauma patients for sure. I wonder with trauma patients if you could do a bit of a partnership with your trauma service to see if they can get the patient pre-op for you if they come to their trauma follow-up. That might be.
As I told you, like, you know, I think this is the main issue is because of most of them is trauma. And one little problem before you take the filter out, one very little problem, like you need the patient to be present so you can take the filter out, which is, if we don't have him present, it's hard to take the filter out. So, but I hear you.
But do they come to your trauma appointments? Because I feel like some of our patients do come to their trauma follow-ups. So I wonder if we could capture them there. Right. Like if you talk to your trauma surgeons and see if they see the patient and they can just pre-op the patient for you and then just get them on your schedule, that would be a way to avoid them having to come to you for a visit.
Regina, do you have any feedback about our follow-up for the trauma patients for filter retrieval?
No, because we don't follow this. We don't actually participate in this registry with the VQI, so I don't have any data at all or any way to look at it.
There you go. So it's not it's not Charleston's fault if our numbers are not good. All right, but we're doing very well. So that is all of the data for this portion. If people have any comments, I would love to hear them. The way the rest of this meeting is going to go is we're going to have the presentations for about 45 minutes. We have 3 presentations of projects, and then we're going to talk about how we as a region can come up with a good project to get us all working together on something. We came up with some ideas that I'm going to definitely, I kind of just want to really get logistics on today from our ends. So we'll talk about that after these presentations. Any comments before we go for a 15-minute break? How long is this break? 15-minute break. Anybody? Comments?
Thank you.
All right. 120? We'll see you back at 120, okay?
Stacy. Grab that one. Grab that one. Hey, everybody. This is Betsy. We're just getting back online and getting situated. And in just a moment, we're going to have, actually, we're ready now. Dr. Sam Stearman from Symptomatic that's going to give a talk now.
Okay.
So everyone, this is Dr. Stearman.
All right, fantastic. Thank you for having me here. Today we're going to talk about the peripheral artery disease, vascular rehab, supervised exercise therapy, and then advance into the experience that we've had at Syntera. And I'm willing to even say success we've had in Syntera, definitely on an individual patient basis, and we're working towards more therapy for more people. Doing this right? Okay, so besides being my title slide, this is the front of our vascular rehabilitation pamphlet and guidebook that we give to our patients as well. To give you a little bit of history, so I think I'm not telling anyone new here, that peripheral artery disease affects a large portion of the population, millions and millions of Americans, 7% of the population. If you look at the greater than 65-year-olds, it's about 12% of the population. So a lot of people are suffering from this. Oftentimes it's claudication before or instead of progressing to their ulceration. And that can't be right, 202 million people worldwide seems like a lot. Similar risk factors as other vascular disease. And I don't want to gloss over this slide because these risk factors are really important as we talk about the treatment we're going to have for these patients in the vascular rehab. You want my video on?
Yes, if you can do that one.
Put the video on? Okay.
Yep, there you go. Sorry about that.
Okay. So the actual risk factors are going to matter as we talk about how we do vascular rehab. So it's smoking, it's hypertension, hyperlipidemia, diabetes, and then managing them as well. Particularly smoking, that's one that we're going to harp on in a second. What is the background of vascular rehab? It was first introduced by multiple societies back about 20 years ago. And then it was a clever trial that was published in 2014 from the University of Minnesota that really compared supervised exercise therapy versus stenting versus surgery. And they found there's reasonable evidence to support this non-invasive way of managing vascular claudication compared to the invasive ways and the more expensive ways too that we take care of these patients that have higher risks as well. 2017, the Vascular Disease Foundation provided the framework for what we use for these PAD toolkit rehab programs. And then it was 2017, this was sort of the big speed bump that we got past. CMS decided that they were going to cover it. And then that gave us the green flag to be able to take care of more of these patients. And you can see the rate at which they cover it. Private insurances we're still working with to figure out the best way to manage those patients. Thankfully, a lot of the patients are Medicare. So when we pay from the PAD, there's two separate buckets of things that we want to improve on, both of which are going to be affected by supervised exercise therapy. They want to walk further. They want to have improved quality of life. But we also want to decrease the cardiovascular mortality and morbidity that goes along with peripheral artery disease because there's often concomitant coronary disease, cerebrovascular disease with the PAD. So we're working towards both of those with vascular rehab. Exercise training is a key component of therapy. When we talk in the office, when I'm sitting with my patients, we talk about that as part of a whole program. So it's just a piece of a comprehensive vascular program. Pharmacologic management, as well as risk factor management, as listed right here, but that's going to help in vascular rehab as well. So why does walking help? Why does supervised exercise therapy make a difference? And the true answer is we don't completely know. There's a lot of theories that go on. What it comes down to in general terms, we either think that the muscles get conditioned to be able to tolerate less blood flow. So they get this ischemic conditioning as they walk with less blood flow. And maybe just the fact that the resistance drops, the ability for more blood flow to be soaked up by that muscle bed, additional collaterals can grow to improve the circulation down that leg. The corollary would be, well, does biking help? Does swimming help? We're not exactly sure. We know that walking is that key exercise that will make the difference. And I'm not telling anyone to stop any sort of exercise that they want to do, but it's really the walking that we can say with good studies that it makes a difference. So our goals, decrease the symptoms of intermittent claudication, improve the the pain threshold, and then slow progression of the disease. When they come into the vascular surgery, supervised intermittent claudication, supervised exercise therapy, we make sure they don't have any contraindications for exercise, and that's done within the office setting with the physician. And then the assessment that is done in the center is hemodynamic assessments, baseline vitals. They go through a history as well. And then there's these questionnaires that are used to help determine what the baseline is for these patients before and after they go through the programs. And multiple questionnaires are used, which I'll have some data about as well over time. Then they're evaluated, and there's the protocol that's listed right here. This is mostly treadmill-based therapy, first at a flat and then in an incline, to try to get them to walk where they're comfortable and then push their level of comfort. A physician must refer these patients to supervised exercise therapy. The way that we've done it in this entire system right now is it's really part of the comprehensive care of the peripheral artery disease patient. So we really want these patients to pass through our vascular surgery office, our providers of peripheral artery disease, to go through all of the other components of care for these patients. It's a 12-week program where they go 3 times a week, ideally. At the end of the 12-week program, they can be re-enrolled for additional time, up to 72 weeks. And the really successful patients do continue that and use it as a bridge to their own lifestyle changes that they make, where they walk on their own, either on a treadmill or outside. 30 to 60-minute sessions. Really, it's you want to walk till you hurt, till you can't hurt anymore. You stop, you let the pain go away, and then you continue to walk. With physical therapists right there, they're able to coach them to be able to do that. Here's the beautiful part of rehab. They're stuck on the treadmill right next to the physical therapist. So the physical therapist is going to say, have you had any cigarettes today? When was the last time you saw your doctor about your blood pressure? How's your glucose doing? That makes a key difference, as well as adherence to the exercise. They document vital signs during the procedure, as well as the exercise tolerance, and we have some data on that as well. This is more of the protocol that's done, assessing the pain scale that they have pretty frequently on a simple 1 to 5 Likert scale, and then increase the walking time. Here's more of the protocol, and then there's a cool down period as good physical therapy tenets will allow. This is a little bit more about the education, talking to them about stress management, exercise. Smoking cessation is, as you know, really the biggest risk factor for progression of disease and a problem. Was there a question from the etherweb? Oh, okay, bless you. And then a goal of maintaining the exercise at home so they get the tools and the tips necessary for that. At the end of the 12-week program or the longer period, we'll do a post-procedure assessment to see, did any of this work? So what we've done so far within this entire system is design that vascular rehab handbook, which is about a 12-page handbook, talk about what to expect during vascular rehab, as well as the risk factor management that goes along with it. To streamline the process, we've used our electronic medical record to satisfy the CMS requirements, such as can they have exercise? Well, it's easy for me to put in a dot phrase, which is a quick way of putting the information into the medical record. They're cleared for exercise therapy, and that's no problem. The order had to be built, as well as the charges, which is some behind the scenes stuff. Clinical education and tip sheet, I'm going to show you that in a second. And this, we have multiple customers, as it were. We have the patients who have the claudication, and we have the physicians that treat PAD. So we need to get the education out for most of those situations. So here's an example of one of our rehab flyers. This was our first center that we opened up in Rockingham, showing a picture of what's familiar to these patients, and then some of the things that we're going to do while we're going through rehab. You can see who's involved in it. As we flip it over, it's a very brief outline of what we've just talked about over the past several minutes, talking about what the program is like, and then how we're going to decrease all the risk factors for peripheral artery disease. And this has been our experience. We started in April of 2018 at Careplex, and then followed by Rockingham. And slowly we've been rolling out to more of our hospitals, because proximity is really very important for these patients. They're not going to go very far to be able to do this. My center is, I won't use the mouse. My center is Virginia Beach General Hospital, which is the third one down. We've been open since July of 2020 and had some very nice results anecdotally from the patients that I see back in the office. We're looking to expand. So Princess Anne, Tara Lee, and even further are things that are in our sites. And here's the nuts and the bolts of what we've had so far. Interesting, if you go down this spreadsheet, you can see the number of physicians or number of patients that were ordered for vascular rehab, which is highly variable. So there's an opportunity right there. And the number of patients started. Look at the drop off already of the patients that have started. So I think there's more education that's necessary for the providers to be able to, I don't want to say sell the program, but explain it a little bit more and the benefits of it compared to surgical intervention. Even less patients are able to complete it. And I'm okay with some of that drop off because some patients aren't able to continue to complete it. And I'd rather have them be sent to vascular rehab and fail and then need an intervention than to just go straight to intervention. We'll be able to avoid more interventions that way. Number of patients active, you can see, so it's not overwhelming any of the centers. These are typically cardiac rehab centers that have some opportunity, some extra treadmill. It seems to be fairly easy to incorporate into a cardiac rehab facility. So the percent started, the percent finished as well. These patients that completed are generally happy with the result. This is one of our Excel spreadsheets that shows the individual patients, and it shows, and this is how we're able to input the data to figure out how the patients are doing, particularly the scales that we use to determine where the patients start and where they get to at the end of the day, excuse me, and as well as some comments. Seems like all these patients have a comment about why they have to stop or pause things along the way, and that's life, and we're going to roll through with that, and that's okay. So our next step, what we've learned along the way is best practice alerts, I think, are going to be helpful for some of our providers that don't quite understand the ins and outs of vascular rehab. When they see these patients, maybe there should be a pop-up that say, consider vascular rehab. Continuing to roll out to different sites to make it easy for the patients to get there. I think we have to measure success when we're doing something like this, both to make sure we're doing the right thing and also to be able to tell our patients there's a really good chance that you're not going to need a procedure. I know you hurt right now, but if you work through this, we're going to get you through without having to have something done. And the last thing would be outreach to promote this program. It's pretty unique in the area, and we'd like to be able to send more patients through it. So that's what I have. I realize I was talking very fast, but if anyone has any questions, I'd be happy to answer.
We're talking about implementing supervised exercise therapy as a regional context because we struggle with our rural patients and our small clinics across West Virginia. We order all the time, but really actually that. So how, can we come together as a region to actually talk about what's available? And we as a region try to include that resource to our patient population. So really excited that you're talking about this, and hopefully this is
we're not engaging with any part of the discussion. We're not hearing whatever has been said.
Oh. You already know. But yes, they can't hear us. Or
okay. Sure. The comment was in the western part of the state. There's not the ability to do the supervised exercise rehab. It sounds like it's too far of a distance between the patient and the centers to be able to do this 3 times a week for 12 weeks, which I can appreciate. When I present this to my patients, I actually present 3 different options. I tell them the exercise therapy is helpful, walking is helpful in this situation. I tell them there's 3 ways to do it. You can do it on your own, and I explain you walk to the point where you have that pain and you have to stop and then keep on going. There are apps available to be able to track you over time and give you some more of that feedback. I think one is actually distributed by the Society of Vascular Surgery. And then, or the best way of doing it is to go to a center where you're responsible for showing up 3 times. You have someone there to be accountable for, and that's where we get the best results. So some people do pick doing this on their own. I think the population that has claudication isn't so into the apps as much, but you gotta. I feel like I need to convince the patient that it's a viable way of treating this because it's not a magical pill. You got to work at it, whether it's driving there or working on a treadmill.
I'm going to just talk to the microphone.
Go, please.
I'm just going to mention, so after these presentations, we're going to lead a discussion about this as a potential quality project for the group. So I'm talking in West Virginia and in rural areas. I go to a mountain clinic 2 hours south. No physical therapists there have that program as an option. Patients are still driving 3 hours to see me from there, and they don't have cars. So how can, and we know that if a non-supervised program is not recommended, that is not gold standard or evidence-based in the guidelines at minimum. So we have to see what do we have as resources in the states that we're working in, because you can do directed, so supervised but not in person is still considered an option. Okay. But you know, what centers actually have that is a question. So we'll talk about this very shortly. So hopefully you'll be here for the next hour.
Sure.
Fantastic. Any other comments from the group? Online?
Hey, this is Bazat Farah, one of the vascular surgeons at UVA. I have to echo that sentiment. You know, we're in Central Virginia, there are patients that drive 2 to 3 hours to come see you. And if the physical therapy is not within a half an hour drive, they will not do it. So it's a challenge, certainly.
Sure, thank you for that. So what we're seeing in the room is that maybe by using some of this data, we can make some policy changes at some of the outlying facilities. Great, thanks.
Thank you so much, Dr. Stearman. So our next speaker is Chris, and she's the PH Director of Clinical Data at Winchester Medical Center.
Next to. Okay, welcome. Great. Thank you. It is actually a pleasure to be here speaking to this group. We have done so much at Winchester based on the group's work that we're very, very pleased to be able to offer something in return. I've been at Winchester 40 years, and so I've been around the block, signed a lot of things. Most of my work has been in cardiovascular. This is us, so Winchester Medical Center. We actually are the starship of Valley Health. Valley Health has 6 different sites. Only one other site is acute care, and that is Warren Memorial. Down in the bottom left, you can see that we're right on 81. We also are on the intersection of 50 and 522. So we do get a lot of trauma traffic coming through, although we are a trauma 2 center. And unfortunately, I have nothing to disclose. All right, why does it matter? Why does follow-up and follow-through even matter? Well, here's what I consider a lifeline, right? All right, you start out at birth, and first thing that you might remember are the terrible 2s. You spend a lot of time in education, and you're so excited you get to young adulthood. And maybe you get married, maybe have children, and the children leave home, but those same children will come back, I will guarantee that. So what happens? They have grandchildren, and you are so excited to watch your grandchildren go through terrible 2s because now it's on your kids, right? So you're really, really out there. But when your grandchildren come the opportunities to go to soccer games, go to baseball games, go to watch volleyball. So you have this opportunity, and what happens? As Dr. Stearman spoke a little bit, you have an opportunity now to intervene on someone that has peripheral artery disease, maybe cerebral artery disease. Well, what about that time frame? It's very short. It really is a short time that we have to interact on someone's life. And Dr. Stearman kind of spoke about that after 65. Unfortunately, I'm there. After that, you then may have peripheral arterial disease. So let's make sure that we interact in a manner that extends the quantity of life, but more important, the quality of life. Those opportunities we have for smoking cessation, diet exercise, a medication compliance, and sometimes just a conversation about, hey, how are you doing? Have you seen your primary care? How about your vascular surgeon? Have you followed up with them? Well, let me help you. Is it trouble getting an appointment? We can help in this manner. So that's what we do. So I'm going to talk a little bit about our follow-up process. We all know that it's between the 9 and 21 months. My staff kind of likes to do it right about a year. They feel that that gives the patient enough time to come through the process. I have 3 different people that work in my area for the VQI. One person does PVI, carotid stents, and carotid end darts. One gets infrainguinal, suprainguinal, and vascular medicine. And one gets the endoaortics, the thoracic and complex endovasculars, and lower extremity amps. And so I took the numbers here, and you guys are probably sitting there and go, these are queen people. Look at all they have to do. This is all they do, right? The annual volume for my carotid stents, end darts, and PVIs is right about 578. Then as you go down the line, man, you know, infrainguinal, supras, and vascular medicine, which is the newer registry, she only has 231 annual volumes. Yeah, she's still following up on hemodialysis filters as well. So she's about 152 annuals of those. The endovascular aortics and the thoracic guys, he must be sitting on gold. He only has 149 annual volumes. But think about all these, if you do all of these, you think about what the actual data collection looks like, and you know that the data collection in all of these are not the same. There's a lot more involvement. Now we participate in 9 of the 13 databases, and yearly I take an evaluation. What have we gotten from that database? What have we gotten that's making a difference in our patients? So we have dropped open aortic aneurysms with very low volume. Actually, for 3 years, we had 0. So we dropped that one. Hemodialysis, yeah, there wasn't a whole lot of data coming out of them for us. So we dropped that one in lieu of getting the vascular medicine registry. What we saw in this registry now was the opportunity to follow a patient, not just through intervention, but prevention. When the person first gets diagnosed, how can we follow this patient to prevent an intervention? Now, the reason we took vascular medicine is because our lower extremity amputation rate is very high. That concerns our physicians and actually concerns all of us. Also, what was high in that area were the guillotines and going back for revisions. We were very concerned about our population, so now we had an opportunity to look at them earlier. So that's all they do? Sorry guys, it's not. Everyone in my team wears multiple hats. We support a total of 20 databases, so timing is everything. The first set of hats there is Barbie. And I can tell you that Barbie also does LAAO, which is a mandated CMS registry. She does atrial fib and ablations, and we have a homegrown ablation registry that she monitors. Now the other two, Kristen has lots of hats on her too, and she does the infras, supras, and the vascular medicine. She also is my timekeeper and the person that's responsible for my budget and keeping track of our expenditures. And Mark is very, very unique. He's the one that has the endo areas. He actually used to, in his former life, was a programmer for AOL. So he has a significant involvement in IT that we use all across the hospital. He supports the critical care areas and all their databases, and he also is responsible to support ASR. Now, ASR is a neuro database, and they're just getting their feet wet, so they're still very, very young. So he has a homegrown database that monitors our neurological population, and we're trying to send those informations to ASR. So he's very busy with that as well. In addition, he does the harm database. So he supports the entire hospital in their harm project. So yeah, these guys wear many hats. And I am fortunate at the very bottom, I just have one. I'm just the VH Director of Clinical Data. That's all I do. Okay, so let's talk a little bit about our follow-ups. We all know that it's a 9 to 21 month follow-up range. And the first person at the top is Barbie. Barbie, can you talk? Wasn't sure if she's able to. Can you take yourself off mute, maybe?
Yes, can you hear me?
I can. Barbie, I want you to tell a little bit about yourself and a little bit about your follow-up process for your carotid stents, your endarts, and your PVIs. Take it away.
Sure. So my name is Barbara Gallagher. I've worked at Winchester Medical Center for a little over 25 years. I spent almost 20 years in interventional radiology as a tech. So I was very familiar with the database when Chris hired me to work in her department. And I worked very closely with the doctor's office. about 82% in 2020 of our cases were done by our vascular doctors. So I started working with Megan Collins, and she's one of the PAs, and we got together and we had a meeting and we discussed the window, and we decided that the best way to get the patients to come back would be to talk to the office. So we got the girls in the office to schedule the patients at about a year, as Chris had said. And if every month when I do my PVIs for this year, I go back to last year's. So here I'm in March. So when I finish up my PVIs for this month, I will go to March of 2021 and start my long-term follow-ups and do them for the entire month. And the ones that didn't come back for their follow-ups, I will keep in a file, and I will contact the physician's office to see if these patients can be scheduled within their window. And when I'm done doing that, I will run a drill down report every month to make sure that my long-term follow-ups that have fallen through the cracks or haven't shown up, I will make sure that it matches the database so we're not missing anybody. And I will continue every month to check my follow-ups to make sure someone didn't come into the emergency room or come into a doctor's appointment through their general practitioner. And after that is done, if it gets closer to the end of the window, maybe 6 to 8 weeks out, I will start calling the patient, because sometimes it takes a while to get a hold of a patient to go through their follow-up. And that's about all I do, Chris. I keep at it.
Thanks, Barbie.
Sure.
Now you see at the very top, that's Barbie. Okay, she's very fanatic. Like January of 20, she's in January of 2022, goes back January of 2020, let's check, let's see where we are. She tags them if the patient is due to come in and hasn't come in yet. Very, very specific process. And to the left of that very top little box, you'll see what her completion rates are for 2020. 100%, 99%, and 98%. So you know that this is a process that for her works very, very well. The second person is Mark. His little process is every 6 months, he generates that follow-up form from M2S, the list, and he checks Epic, and he checks the care everywhere, and he looks for all the contacts. He checks the obituaries. We check the SSI death index, everything he can do to contact this patient. He does not actually call patients, but he follows up with the offices. Well, let's look at his 2020 rate. Lower extremity amps, 9%. Thoracic and complex EVAR, 0%. Endoaneurysms, 3%. Okay, very different than the follow-up process for Barbie, very different results. Kristen, can you talk? Okay, Kristen, I can't hear you right now, but I'm gonna start, okay? Now, Kristen runs follow-up reports from M2S. She does hers quarterly. She verifies the follow-up window, and she continues with routine checks until that 21 months. She contacts his PCPs, checks the obits, and talks to the office as well. But for her, even if the 21 months is exceeded, if she finds a note, she will still put that in, because to her, it's important. Even though it's not going to count, she wants to follow those patients. So she has that information. So if we take a look at her procedural types, hemodialysis is 5%, infras 5%, and supras 13%. Okay, so again, a little bit different in percentages, and maybe I would get excited, but I don't, because it works. Whatever they do works for them. Here's our follow-ups across time. We're the blue and VQI is kind of like red. And we got the VQI rates from the spring dashboard reports. So we started in 2012 and we had about 85%, we're just okay with that, and 90% in 13. I don't know what happened in 14. I don't know if people were asleep at the wheel, if I was asleep at the wheel, but 50% follow-up. So we're like, guys, we got to do something. We got to check this out. So this is when they put into place their own methods of follow-up. And you can see now we've been above 90%, and actually we were 98% this past report, and that was the top quartile. So here they were. These were our percentages for 2019, and you can see, true to form, stents and endarts were at 100%. Now, infras and supras, also Kristens, and you saw the lower percentage that we saw in 20, they were 100% by the time we had to do our report. So overall, we were at 98%. One that really surprised us here was lower extremity amps. We were at a 95% follow-up, and this is a notoriously hard population to get to call you back or to get in contact with. Even PCPs lose track of these patients. So when we had a 95% in lower extremity amps, we were absolutely thrilled. So again, this is the work that they do. I do not do this work. I am just have the opportunity to appraise them for the work that they do. Okay, so the Vascular Medicine Registry. When that first came about, the first thing I did was say, oh no, my doctors are gonna wanna do this, and I'm pretty sure the number of patients is gonna be astronomical. So we said, okay, we'll look into it. So, well, if you tell your doctor looking into something, it's a done deal. You know, you're gonna do it. So we said, okay, we're gonna have to start slow. We're gonna start only looking at patients with vascular surgeons that do their care. I said, let's try that. Let's try to identify those patients and follow them up. Well, about at the same time, our hospital was interested in the limb salvage program that WVU has spoken of many, many times, and we were so excited. We said, let's see if we can do that. So we started with a limb salvage program. We involved podiatry, vascular surgery, the wound clinic, and us outcomes, because someone's going to have to put out that data. We now have a hotline, B540-536-SAVE. And we're pleased to say we already had one call. So we're very excited about that. We started now with Wi-Fi documentation. If you're not familiar with that, that is the wound, ischemia, and foot infection scale. And the higher the scale of that patient, the more at risk they are for interventions on that patient. We see patients in the office, we see patients in the hospital, and we pick up patients in the wound clinic. So we're getting these follow patients from all over the area. That follow-up as the result is there's a responsibility for Kristen Ford. Now, a lot of you may wonder, what is the background of all my people? There only is one nurse that does VQI, and that is Mark. As you heard, Barbie is a rad tech, and Kristen is a person homegrown from us within our area, within I've been working with Kristen for a long time, and now she's so excited about education, she's working on her BS, and she plans to do her master's. So there is an area that in me wants to grow people, and I think that's an opportunity that we have. So anyway, she started collecting the data July 1st of 2022, and we now have almost 200 patients in that database. And we know that traditional follow-up is 9 to 21 months. But she's not satisfied. Independently of any physician, she said, I want to follow that patient. So she sees them, she checks their charts every 30 to 90 days. She records procedures and tests and gathers beneficial information for her clinicians. Now, in the M2S database pathways, you can put in more than the 9 to 21 months. So she's actually entering them into pathways so we can pull that data. I want to thank you for the opportunity to showcase my most amazing team. Any questions? Don't bite, I promise. Okay, thank you.
That's great. In October. Thank you, Chris. All right, next is Stacy, and she's going to talk about her multi-regional elective EVAR SPS guideline quality project.
Hello everyone, I'm Stacy Jardina. I work at WVU Medicine with Dr. Mintz.
Back in 2020, our center decided to take part in developing a multi-regional elective EVAR SBS guideline quality project to evaluate mitigating factors for the surgical treatment of small aortic aneurysms not meeting SBS guidelines. I know some of the VVSG centers took part in this, so I just wanted to give you guys an update on it. For those of you who don't know about it, I'll give you a quick rundown. WVU Medicine joined with Cleveland Clinic as well as Stony Brook University and Albert Einstein Montefiore for this project. The charter originated at Cleveland Clinic with Dr. Chris Smolik and data manager Donna Fleming, and it evolved into a multi-regional project. The core group listed here initially met to discuss the scope of the project and identified the list of mitigating factors. The reasons were created into hashtags and sent to and approved by the SBS PSO. The centers that agreed to participate retrospectively collected data from January 1st, 2017 through December 31st, 2018 by entering hashtags into the comments section in Pathways. This was completed by February 28th of 2021. As you know, the SBS sac size guideline looks at elective EVAR cases and what aneurysm size surgery should be performed. The guideline is greater than or equal to 5 centimeters for women and greater than or equal to 5.5 centimeters for men. Currently, there's no way to capture any of these mitigating factors in the VQI. And approximately 14 VVSG centers participated out of the 38 total that we had. This is the list of hashtags along with the results. As you can see, we had several of the mitigating factors that were frequently used for reasons for treating the smaller aneurysms. We did have 623 patients that had hashtags entered. However, 12 of the sites with a total of 29 additional patients had more than one hashtag entered. While we had sent out education on how to do this, it kind of got skewed in the process. And the total number of patients with one hashtag per patient was 594. While we had included a free text option to document other reasons, we learned that M2S was not able to include the free text option in the data pool, so we ended up losing that data. Yep. Can everybody hear me?
Yep.
Let's see. It also would have been helpful to have known how many EVARs were performed at each site to have a better understanding of the percent of size compliance. That was an oversight on the committee that we didn't think about. We also didn't realize that we wouldn't be able to know which centers and how many hashtags they entered. It was all blinded, and we weren't aware that that's how that was going to work out. But based on the responses summarized, we felt that some of the common hashtag responses should be added in the new variables in future AAA module revisions, and we listed them here. The ability to note these exceptions in the EVAR SBS sac size guidelines section of the regional report would provide a much more accurate measurement of the sac size guidelines compliance. We've shared the data with the physicians who are listed as our core group for this project, and we're eager to support any requests for further quality research projects on the data collected. I'd be happy to discuss any future projects that our region would be interested in pursuing based on this project. I know we were talking about whether we could do this as a regional project and kind of move that forward. If everybody was interested in doing that, we would kind of reevaluate the way we did it before and tweak it a little bit to make it more, to get better data. We could even look at some long-term follow-ups on these cases based on how the aneurysm was treated. Does anybody have any thoughts on that or questions?
Long-term data follow-up is really important. You know, we all have reasons for that list seems very reasonable, right? But when we look at long-term follow-up on patients who are treated for appropriate SBS guideline treatment, we don't really make an impact in their survival. So it might be interesting, you know, we treat aneurysms, but we don't really help patients long-term with their survival. Giving an example as treating an atherosclerotic disease all seems really reasonable, but if you can, nobody really does it. They always talk about it. I've been talking for 35 years. I've been having the same talks for 35 years about we need long-term data follow-up, but nobody ever follows up with long-term data outside of really major trials like the UK small aneurysm trial or Adam trial. So if you can track these patients, even 5 years, it would be really, really valuable, I think, to look at some of the things we all do. You know, I don't disagree with anything, we'll stuff up, you know, it would be really nice to know that not do they rupture, but do they live, right?
Yeah, and I think we could do that as a region.
We did not hear the comment. Can you, I know it's a kind of long comment. Can you summarize this to us?
Yes, the comment was how important it is to get long-term follow-up on survival of these patients after the surgery, and that we could use that as a regional project and really look at the long-term follow-up over years, up to 5 years. And I think we could do that with, you know, specific centers. Obviously, the data managers would have to be really involved to want to put that further follow-up in. So it would take that commitment to be able to do that, but I do think it would be worthwhile. Question is, does Vision have all that?
Thank you, Stacy.
Dr. Maribi, do you have any comments on the Vision data, or do you know if the Vision data has that? Or did she have to leave? Dr. Maribi, any comments at all? Oh, thank you. Thank you, Stacey, for that. That was a great discussion. All right, and then Dr. Hughes is going to come up. To the middle of the room, and then people can talk. It'd be hard to have a back and forth conversation. How far does this mic travel? All right, we're going to talk about, you know, doing something regional. That is a short. Oh, if people can come. Can you all hear me?
Yes.
Okay. We're going to mess with the slides. We are going to talk about some ideas for the region. And we may have people just kind of come up right now to the microphone so that the people online can hear. You guys want to come a little bit closer? We're trying to see if someone can provide a microphone that we can plug in. Yeah, but this one is very short, so I can't get it too far. So kind of, we've reviewed the data and we've seen what our region is dealing with, where we're at, and what we can offer, right? You know, this long-term follow-up has always been something that's been of interest to the region.
I was actually curious if
Hey, Samantha,
yes.
stand on the other side of the microphone so we can hear you better, because now we're not hearing anyone, including you.
Can't hear me right now?
Very, very muffled. Come, make sure the microphone is near you at least. I'm sorry.
Yeah, when you turned away from the microphone, it got really hard to hear.
Are you hearing me on this microphone or on the computer itself?
It's a good question. I'm not with you.
Can you hear me better here?
Yes.
Okay, well, we can walk around the room with the computer.
Oh, that's true. Use our phone.
Sure, we can have people do that, but this is gonna be. Yes, we can use one of our phones as a microphone. That's so smart. Okay. Thank God for data managers, am I right? Yes. All right, we're gonna have like a phone that we're gonna pass around like a microphone. So if y'all didn't hear me there, so we all got a really good idea of what our region can offer and what we have data-wise. I wanted to just hear from the data manager group what your committee talked about, if you have some take-home points for us. Anything interesting, any interesting projects? I'm just getting some shrugs. All right, well, let us know. So things that we talked about that could be interesting for the regions. And the thing I got really excited about with, especially, so, you know, Darren started mentioning, okay, we'll do that, but Darren started mentioning, you know, the potential for making policy level changes at the government level with supervised exercise therapy programs that we could potentially bring our information to. I know for us, West Virginia is very dependent on the university for all of its public health efforts and initiatives, and they really listen to the university when we bring things to them. So for example, again, I'm just talking about the supervised exercise therapy. This is a guideline directed medical therapy. The AHA has said this is #1 requirement for anybody that's going to have an intervention. AHA has said it, the SVS has said it. That is an evidence-based protocol that is not being widely implemented or adopted. So it's an ideal target for an implementation science type project, which marries very well with quality. So we can even start with a needs assessment across all of our participating centers to see, so we can create a SurveyMonkey survey, send it around to everybody, and just find out what do you have available to you for walking programs, supervised walking programs for your patients. We can find out if there's a mobile option. We can find out, so if there's like an, you know, if someone's, is there an app people are using? Or if, you know, because there's been funded research looking at using just coached programs, like McDermott's done a bunch of research in that area, Mary McDermott. So we can see if there is mHealth stuff being used for that, or we can see if there's in-person. And again, I've just worked with, personally, I've worked with physical therapists directly and asked them if they can, you know, if they're willing to start one in their institution. And so that's how, like in my middle of nowhere hospital, they've been able to start offering it, but I still have patients that come to me from there that are too far away to utilize. So I think if we can get an idea of what everybody has as an option. The other thing that I know is that in West Virginia, Medicaid does not pay for physical therapy, period, for patients. So if you're not Medicare, it won't pay. But if we can say, we bring this information to our, you know, government leaders and say, you know, this is the evidence-based guidelines, you're not paying, and this is how much it's costing you because these patients are getting interventions, there's the possibility of making change. I don't know how it is in Virginia, how you guys are tied with your governments, but I know that WVU is very tied in and we provide a lot of recommendations and programming. So these are just, I think doing a needs assessment might be really helpful. My question to everyone is, to the data managers, is there any way we can capture this information in the PVI or the vascular medicine module? Is there anything about exercise programs, therapy in either module? Okay. So we can make this a VQI project if we can see. I don't know how many centers have Vast Medicine module.
Very low.
You gotta mute that.
Medicare is keeping track of this. I only know this once in a while I'll get a letter saying medications and using
No, so Dr. Stearman was just saying that Medicare sends him a letter showing how many patients he's done an intervention and how many of his patients gotten supervised exercise therapy. I've never had that. Has anybody else here online ever gotten a letter from Medicare about that?
Nope. Sam refers a lot more patients to than I've referred one and they didn't show up. So we have a really good physical therapy department. I have referred.
And the phone to him. So he can... Oh yeah, come on up. That's fine, but he's gonna come up. Come on up. So just introduce yourself and what center you're from.
Like it's Centera in Charlottesville. So Sam is the master of referring patients. I've referred one Medicare patient that didn't show up for their appointment, but I've referred 4 insured patients because, just like was mentioned, these insurance companies are very much in tune with do the vascular rehab before they allow intervention. Basically, they deny payment. So they mandate that they do physical therapy, but they won't pay for the physical therapy. Has anybody else run into that problem with insured patients? I have. That's my biggest roadblock. I've got 4 that need one. The very young guy needs an iliac angioplasty and a fem-fem. Fix the guy, and he can go back to work doing his construction job. He can't get approval for the physical therapy, even though his insurance company mandated it. So what kind of road, how do we fight that roadblock? You know, all the Medicare patients would qualify for it, and it seems very reasonable to send them for it if they're willing to travel. Same issue in our place. Torture. Pay a lot of money for healthcare. Don't get anything for your money.
So that's a really great point. Does anyone care to comment on that online?
Hear it.
Darren, you looked like you were about to say something.
We didn't hear the question. We didn't hear the comment.
You guys didn't hear that comment just now?
No.
You can hear me though.
Now, yes.
That was a great comment. I'm very frustrated. Hold on. Sorry?
Darren, you hear me?
Yeah, I can hear you out
Yeah,
there.
we can hear you.
So basically the question or the comment I heard is very well on my side here, but it's basically he present like he does have a 4 Medicare patients, and one of them need some intervention, and he went to do the intervention.
Oh, he just froze.
No. Insurance is mandating for him, for this patient to have supervised.
Yeah.
However, need to be qualify him for surgery. The insurance is not paying now for the supervised. Like he is not allowing to pay for the intervention. He wants supervised exercise. When he sent to the supervised exercise, the insurance is not paying. So they put him in the corner, like he cannot do anything to, to proceed with his patient. So he was asking if any one of us has any kind of like similar situation. For myself, I never had any situation like this. With just the documentation, we can proceed with the intervention. I mean, this is to me like life limiting condition, and I think this guy can be under the CTLI which he can be like, we can proceed without even supervised exercise program.
Yeah.
But I hate to hear like this has happened to other people.
I heard John's comment. I thought he made another comment after he sat down that she was referring to. But I do think I have not gotten a letter from Medicare talking about who can have it and who can't, or Medicaid saying that they'll deny, Virginia Medicaid denying somebody any exercise program. Part of the problem is what Bazad was alluding to and we talked about on the executive committee a little bit earlier. And John and the folks over at Martha Jeff understand this too, that most of the patients we treat are not local patients. And so even if you talk with them about exercise or structured or looking into their insurance paying for the physical therapy structured programs, they're from a distance. And so they're not going to come to Charlottesville or, Charleston or Morgantown, 2.5 hours away to do their structured walking. And so how do we as a region work through this and identify a way to take it to the two legislatures or wherever it may need to go, try to figure out where it needs to go, to try to create a system where we can think about placing physical therapy and treatment for, a non-invasive treatment for peripheral arterial disease in places where patients live.
How many of you all are on the vascular medicine? Just because I think a good starting place is to look at how many of your patients at your institution are getting it, because I will tell you, I order it a bunch, but like Dr. Stearman showed, there's a lot of people that get it ordered, not a lot actually get it. So if we are able to use the vascular medicine module, you'll see which patients are actually participating, or at least you can actually have your nurses track and see what's going on. And that, we can ask that question if we make like a needs assessment survey monkey.
Yeah.
We can do something like that and see, how many are ordered, how many are actually getting therapy.
I'm pretty sure that we're not on, at UVA, we don't have the vascular medicine module now.
In here.
I don't believe. I'm pretty sure not. We've done a pretty good job internally of actually creating a structured exercise and PT program within our cardiac rehab section, but the applicability of it for us is so small based upon where our patients are from.
Dr. Stearman, did you guys do a needs assessments initially to see how many patients needed it, weren't getting it, or anything like that? Can you come up? Sorry. Is that microphone working?
So,
can you guys hear him if he talks here?
Yeah.
Okay. So our needs assessment was more just in talking to our local 20 vascular surgeons about the frustration with inability to do any sort of exercise therapy in a way to get meaningful results. We didn't have a way of searching our medical record to determine how many patients we could affect, but I don't even think we're near capacity or near even market saturation. There's so many more patients that could benefit from this, both that we see in the office and that our own partners don't think about on every single patient, as well as the patients that are being only seen in the primary care physician office, and they know they don't want an intervention. Why would I see a surgeon if I don't want an intervention? So yeah, there's much more opportunity to use this.
I guess some question of whether or not the physical therapists have capacity for the volume that you might bring in.
That was an initial concern, particularly from the physical therapists, that how are we going to fit all these patients, but it hasn't been an issue. The physical therapists enjoy seeing the PAD patients, and as you could see, the busiest center has 15 active patients right now. So they have a lot of capacity, I think, to be able to do it.
Okay. So yeah, I think a great project would be to see how many participating BQI centers actually have access at their institution, and then how many are having difficulties for patients because they're traveling and actually don't have the ability to use it. It's different, obviously, in an urban environment than rural environment.
Yes and no. I present this program. They say, well, where is it? And I explain where it is. Oh, I'm not going over there. It's
It's true. No, you're right. And when I talk about these disparities, I say it's same problems, same problems, different flavors.
Yeah.
You know, you can be very inaccessible even if you're a mile away.
Dr. Abarama, you're muted.
What's that?
Dr. Abarama's trying to say something. He's muted.
Oh, Dr. Abarama. No, you're still muted. Ask to unmute.
I think he knows it now.
So I think I can just.
Oh, here he is.
Yeah, you hear me?
Yeah, wait, please tell us what.
Okay. Well,
Start from the
I've been
beginning.
listening to all of you giving your frustration about exercise therapy and so forth. Let me add one comment to you, which might be helpful. Presently, the SVS position, we cannot push this as it has to be a standard of care where you cannot be compensated if you do not push for that therapy. Why? Because we're aware of it. Most Americans, whether rural areas and even some not rural areas, it's not practical, it's not working, it's not available, it's not going to be. I just heard one of you saying, I cannot see people going 2 hours and a half to find a physical therapy to be exercise or whatever. Therefore, it's suggested, it's advisable, it's great idea, but I don't think I could see it very, very near from the Medicare or Medicaid telling everybody, if you don't do this, forget it. We're not going to compensate you for doing an endovascular procedure or an open procedure or whatever. Now, in the future, it might be, but I could see where you're coming from. Now, what Samantha suggested as a starter to see in the people who had ability to follow this through the DQI and see where can we stand and what we can do and so forth. But keep in mind also, Samantha, not every place where they do vascular participating in the VQI also. So I think it's going to be a little bit long time, similar to what you see in the vascular lab. When I was pushing for 20, 30 years through the IAC, we must adamantly ask the government, you don't get paid for vascular lab testing unless you have accredited vascular laboratory. Guess what? We're at 2022 and it's still 50% of the tests come to our lab. They're coming from place which God only knows even whether they or ever heard of the place or even the doctor heard of the test. And they still get paid for the test. So it's wonderful between our dream and between reality. You are hoping one day it will, but at this stage, I'm not sure we can solve it, at least today. However, it's worthwhile to start somewhere. And hopefully that's helpful to some of you, and you have a good point. I don't think but anyone of my group have received a letter from Medicare said, we're not going to really pay you anything because you did not try or went through an exercise program. At least in Charleston, I have not received this. Go ahead there, Samantha and Albert.
Thank you for your comment. I think it's a great point.
Yeah.
And I think we kind of stand in a unique position where, look, like the AHA made it their guideline and their recommendation. That was part of the SKY guidelines, the recommendation, I forget what they're called, the appropriateness use criteria. I mean, that came out for claudication. They're way bigger organizations than we are. They said it. They said it has to be supervised even, which is just bonkers, but they put it out there. I know the Society for Vascular Surgery document that's still circulating, that's in draft form, says, if impossible, then they can do a non-supervised. But I mean, it's happening. So if we can, I just think we can at least go to the, our governments, our state governments and say, you guys need to pay for this for our Medicaid patients. Not I don't want to bring upon us that they're not going to pay for our interventions, but if they're going to, you know, as you can kind of just see, the guidelines are starting to show up. Certainly there may be interest on the insurers to start causing barriers. So if we can be ahead of that, I think that would be, you know, really, really helpful. And let's face it, better for our patients' survival in the 2 years. Their walking distance, we know, is better if they even do get an intervention. Their outcomes are better if they have a walking program with an intervention than just an intervention. Dr. Stearman wants to say something. I'm going to have him come over here.
Okay, well, I just wanted to interject that while I think this is a great program, I wouldn't support it for all claudicants, and I wouldn't require it as a prerequisite for an intervention for a claudicant. There are those patients that can't tolerate the exercise program, they can't walk far enough, or they're a young guy who didn't know the cigarettes were bad for him, and now it's progressed to the point where he can't work. And he's not going to have time to go to vascular rehab. There's a million situations where it's appropriate to go for a procedure instead of this. So just to be clear, I think it's great. It's just not for everybody, and that's where the physician interpretation comes into this.
However, for our region, I have a comment. I think this can be for those who have significant enthusiasm. This can be like some kind of like community-based projects. In addition, it can be also, it may be community outreach projects. Why? Because I think we are desperate in our areas when it comes to atherosclerotic disease, and we do have significant number of patients who may benefit. As it mentioned, is not for everyone, but some of them, for some selected group of patients, this can be very helpful. I want to just give a tip for a lot of the audience. Like I think SVS, they have the Grand Seed Fund, which this is maybe some idea. It depends on which community and which, like, you know, institution has been sent from. This can be supported as a fund to start some kind of like localized supervisor structured exercise program.
Yeah, does anyone know if the SVS community grants, if any of them have been based on exercise therapy? Oh, we have a microphone.
We're gonna try and see if it works like over there.
Yeah, I don't know. Did anybody know? It was working. Albert, can you hear me?
Halfway. No, not clear. It's still not clear.
I'm just trying to have a microphone.
Right closer.
Closer to your mouth.
Hello? Hello? No, no bueno.
Very faint.
Okay.
Very faint.
Okay. Anyways, all right.
We extremely sorry, guys. You did the great job going in person, and we are like here. I'm the lazy guys, but you know, still.
No, but all right. So I do think there's some enthusiasm. It sounds like if we as a region could start analyzing what's available and
yes,
maybe even come out with a statement.
Yes.
Okay. Another area of interest, we do a lot of carotid interventions in our region. Is there interest in looking at the regional data on our transfem carotid stents versus TCAR or whatever? Some kind of research project that we could come out as a publication as a region on that subject. We got some data, we requested regional data, we're sending an abstract to EVS looking at outcomes with transfem stents and octogenarians, because they keep showing that it's not good, but our regional data actually shows there's no difference. So we may have certain things that are different than when you just look at national data. Is there any enthusiasm for some kind of carotid stent-based project?
Absolutely.
Anybody?
We just have to stop our transfemoral program.
Oh, wait. All right, come up here.
We've all but stopped our transfemoral program and relegated patients to open carotid endarterectomy or TCAR with general or moderate sedation and regional anesthesia. Maybe to support our decision or refute it, it would be helpful, but we wouldn't be able to contribute that much to the transfemoral.
Why did you guys stop doing transfems?
Because of the concern with manipulation of the arch and the local expertise in TCAR. that we've been able to treat the majority of the population that required a stent with TCAR. Every once in a while, there is a transfemoral.
Hear me on this microphone now? Anybody have any comments on that?
I guess my only comment, since I was the one that was kind of talking to you and Albert about it, was that, you know, really the only people that are still doing transfemoral stenting in our institution are the neurointerventionalists for stroke. And they've transitioned a lot of their stuff to transradial. And as a matter of fact, you know, I've helped them establish a TCAR for stroke program for their practice. And so we're kind of doing that collaboratively. My only thought on since we have so many carotid interventions in the region is to look at carotid interventions over time in our region. And if there is an interest in looking at transfemoral data still, you know, how have the patients changed since TCAR has come on board? What are the results of transfemoral CAS since TCAR has come on board, and has that changed at all? And maybe, you know, I don't know how many we would have, but I thought that was one interesting aspect of who's now getting transfemoral CAS in the era of TCAR, and what has TCAR done, if anything, to the results. I thought was interesting. I think really, you know, the transradial access, and as that matures and becomes more and more sophisticated, specifically for folks with acute, you know, neurologic interventions, I think that transfemoral has actually become quite a lesser used technique in our institutions. Dr. Albarama put his camera on, so I know here he comes.
Okay. Actually, let me add something here, since you touched something very close to my heart. I always comment on this wherever I do when it comes to carotid. I think it's injustice for all these studies to be published anywhere, and I dropped my note to the editor of JVS more than once, and to the European Journal. We really are not making sense when we compare any of these modalities together. Why? I'm sure all of you on the phone realize that we're dealing with the different animals. In other words, while we're doing TCAR, we're trying to avoid the arch, and we feel it makes sense, and so on, so on, so. But would you imagine comparing transfemoral to transcatheter carotid stenting as we do? Would you imagine if you do the transcarotid stenting in the same patient, but also crossing the aortic arch? Would you, honest to God, have the same data or the same outcome? On the other side, you go to endarterectomies. Would you imagine if you are doing a TCAR on a patient with a common carotid artery of below 5 millimeter, or a distance of below 5-6 millimeter, or a lesion which is not heavy calcified, or, would you imagine what the TCAR data outcome would be? So many times we do propensity matching and all that crap and stratification, but we're looking to a physiological matching, but not anatomical matching. Therefore, it's injustice for any article to be published really from the ethical standpoint of view to say they are equivalent or this is better than that. It has to be put with a caution. What the caution is, in select group of patients. In other words, in the select group, TCAR did as good as endarterectomy or better. I buy that. In select group of patients, transfemoral perhaps did better than A, B, or CD, because we're not dealing with the same patient population. Do we have a randomized trial to look into this? Guess what? I don't see how can someone take patient with certain diameter in the common carotid and certain length and certain calcification, and now go ahead now randomize it between TCAR or transfemoral, and of course the arch has to be equivalent pathology-wise, and I can see this happening. Therefore, I think for the fairness of TCAR and any stenting, and also for fairness of endarterectomy that all of us love, we need to make sure when we publish this data to say in select a group of patients, this procedure really is really good, because I'm sure all of us do both TCAR and endarterectomy and transfemoral. So I think that itself is not unfortunately being addressed in our vascular literature. And I'll be glad to hear to any comment. And this comment always comes in the last few months, not just by me, by every leader in carotid intervention. And incidentally, we chewed it over a year and a half or two when we put our guidelines for taboo, saying this stenting is equivalent to this operation, but certain patients are good for this, and other for this, and other for this. So I hope to God the junior people keep this in mind for a future consideration.
Yeah, it's really well said. And also the fact that the transradials and transbrachials haven't been included in the data for the transfemoral carotid stentings, that takes the arch out of the equation. So how are those, you know, like, how can we possibly compare that to what we're doing with TCAR or even transfems? I think that changes the picture also.
Yeah.
So definitely an area of interest then, I would say, for the region.
Yeah, an article that I read recently was at centers where carotid endarterectomy is offered, there's a certain complication rate. Where centers where transfemoral stenting is offered, there's a certain stroke rate. Where centers where carotid, transfemoral, and TCAR are offered, the complication rate is lower. To give the physicians the tools, the ability to treat the different anatomy and the different configurations that the patient has, it just makes everything better. So I wonder if there's a way that we could twist our VQI database to look at that for the right surgery, for the right patient at the right time in the right place.
Anyone have any thoughts on that?
That's a great thought. I think it's going to take a little bit of brainstorming to figure out and sit and look at our region to figure out how to come up with something like that. But that's kind of what we were talking about this morning earlier, was just trying to come up with something, because we do so much carotid work in the region. How do we, how do we use this information in a way that can help us further carotid treatment? Or further the way we as a region think about treating carotid artery disease. And so all that's been said is absolutely true, right? We all pick the right patients where we are for what we have, and do the best we can at it. But I love that idea. I just wonder, it's going to take probably, several of us to sit and think about and look at the what we have and what the spreadsheets say, to kind of figure that out.
Also, Darren, I want to get to your attention and all the other audience. I just put it actually in the chat. It came a little bit weird, but I want to commend Dr. Abramo for the last document, the JVS implementation document, management of extracranial. And he discussed all of the thinking we discussed this morning about outcomes. Well, it was actually published recently, January 22.
Okay, so there's interest. All right. What else? I think there was some other area of interest we were talking about.
Venous.
Sorry?
I think we discussed in our EC meeting about something also about venous work, possible.
Was there anything? I know we're not in that module.
Yeah, and we're not either.
Well, I don't think we actually have, as a region, we don't even have enough procedures in venous to participate. Like, we have no venous data.
I think one of the things which after Centera joined us and we have great follow-up, I think any follow-up based project can be a great thing to do some kind of joint project between us on. We have multiple good follow-up. Like, I think you stated in your presentation, we have significant follow-up with good outcome follow-up. We can have something like this, including like, you discussed the octogenarian, but I think in addition to this, I believe like if we add TCAR versus non-TCAR, carotid stenting, symptomatic, asymptomatic, and we can extend, I'm not talking about the short-term outcomes, I'm talking about year or two I think we do have the follow-up for them now. And this can be another project.
Interesting that our follow-up data as a region might be better. I have to look. I feel like, because I was just working with our regional carotid data set, and I think that the follow-ups were a mess, and we elected not to do like 1-year follow-up data on the carotids. I don't know if they were missing information. Like, it could be that we're just kind of documenting that we've made a telephone call or something, but we may not have the actual information that we need in those follow-up sheets.
How about if you ask one of the abstractors to give us?
I know they're looking at me here.
Sure.
Can anyone come up and say something about that? Like, can you think about it? Or Barbie, you're doing the carotids, is that right, for Winchester? Are you still there?
Yes, I am.
Are you getting like a lot of data, or is it more trying to figure out where the patients are at?
That's a good question. Just trying to figure out where the patients are at.
Like, I think the clinical variables are not well filled out. Does anyone from the data abstractor table want to come up and say something?
Barbie, there's a form, right?
There's a follow-up form, but yeah, it has the imaging follow-up actually happen.
It does.
It does.
Barbie, are you, I know I looked at our spec, I actually made the report. I just don't remember what it looked like.
No, so the follow-up form, what are you asking about that?
Yeah, imaging, what are you collecting on that follow-up form? Are you getting the data, or are you just getting the date?
So no, sometimes we get the data. So they're supposed to have a duplex done. And if you get your patient back into your vascular surgeon's office, you're going to get your duplex. But sadly, that doesn't always happen. If I can't get them back into the vascular office for a follow-up, then they're lost to their duplex. That's just, then you're just getting a date and have they been symptomatic or not since their procedure has been done through their general practitioner or whatever.
I know I've looked at the report that they put out. I just don't remember.
I will say, it's just from a statistical standpoint, the follow-up, the long-term follow-up module in VQI is very tricky to work with and can be a little disappointing sometimes. And so we've had to let that go in certain publications where we're just like, all right, we can look at death maybe. We won't even know why they died because it's just not, we found it wasn't documented in I think 80% in our radiation carotid patient publication we just published. It's not well fully documented, but we at least have the data. We can talk about peri-procedural. I don't think that we have what we need to talk about long-term for manuscripts. Is anybody else working with this data that can comment? Sorry, Barbie, you were saying something.
No, that's okay. I agree. I think that unless you can get their imaging studies done, you can't compare them.
Even like medication compliance, we've had trouble trying to figure out, or MIs and like other events. Just looking at the whole country's follow-up data and everything, and the regional data in particular is kind of sparse. Like, we're doing well. That's just interesting. We're doing well, but some of it is just saying like that we've tracked this patient and we've had a telephone call or whatever, but we're still not getting the data points.
It might be too early, but I think maybe a future project would be opioid prescription practices.
So we did have, do you want to come up and say that?
I was just saying that maybe for future files, we can look at opioid prescription practices. One of our PAs actually did a presentation way back, and she's on the national committee for that. And I now know that the opioid practices are available. Is it just in the, I can't remember, infras? Yeah, in the infra. It's a huge list. Have you guys looked at that? Yeah, It's big.
Part of making that list.
For you, well, thank you. Trying to show it to my physicians, I think it took like 4 slides. But anyway, I just think maybe that would be a possibility.
Anybody, interested in opioid projects?
I had thought of that. This is Regina Davis from CAMC. You know, our problem is many of our rural patients see pain doctors. So you're documenting that they're on opioids, but there's no way to know how many refills they've had, how many tablets they have. So you're giving them incomplete data on the follow-up. You know, we have it for discharge, but we don't have it for actual follow-up. And, you know, if there was a way that could be like a checkbox that this was not prescribed by this physician, it would go a long way to help clarify that this patient, yes, he's on opioids, but it's not our doing.
That's interesting to have that ability. I know that it comes up, like we have to do that NARCX check. That comes up on Epic every single time, and you see exactly how many drugs and who's prescribing for a patient. But it doesn't sound like you guys get that either, or don't you have like NARCX subscription?
Yes, we do, but the abstractors don't have that access.
Gotcha.
Providers with like a MD, NDPA have access to that. It's run through the government. Like we reached out to an Epic team at Centera to see if we could get that.
Hold on, I'm making someone come up. Someone's talking.
So when the infrared came out with the opioid, Ashley and I, we were challenged to answer that question on how many pills or what was prescribed at discharge. So we reached out I found out from a nurse practitioner friend of mine that there's a tab in Epic that is just for opioid use in the history, how many refills the patient had gotten. So we reached out to the Epic team, and it went through several chains, and it came back, said the Department of Drug Administration says only nurse practitioners, providers with an NPI number can have access to that. So since Ashley and I are just RNs, we can't have that tab. So it would be on the physician to put it in their note, which is a lot to pull in for the long-term follow-up.
So in Virginia, it's the PMP, maybe.
Yes, the PMP and Epic.
Which has been integrated into Epic, and it would probably be easy to somehow grab that data and bring it into our note if that's something that we wanted to look through. But you're right, it says who prescribed it, how many pills, how many refills.
It would be so easy for us to get that data if we had access to it. But
Like your Epic IT team, maybe.
I'm sure they could.
Pull it into our notes.
This is very important nationwide about pharmacology management. What my ears perked on, the reason I walked up here is for fistula creation, I almost never give narcotics. Someone comes to the hospital for an outpatient procedure where they get an incision in the operating room with sutures to close it, and I almost never give them narcotics. And I wonder if we could look at that across the system to see if there's opportunity, because maybe some of our physicians extenders that aren't comfortable with that are just, being the candy man. So I wonder if there's other procedures that we could limit narcotics, see practice patterns across different parts of the states, excuse me.
I think there's been some evaluations of that. I'm trying to remember if we've done it nationally or not with VQI. Like, because there was they found like varicose vein procedures, people were giving narcotics and stuff. Yeah, it was like nationally, I think, beginning of all of this. Right. Any other project ideas? So for the physicians and certainly the data managers, I highly encourage you, if you're going to VQI at VAM, to all the Virginia's folks to get together when you're there and maybe have like a little cocktail or something and just kind of meet each other and say hi, show your faces. I'll be there, so maybe I'll poke in on that too. From a physician perspective, I'm gonna email you guys, but we're gonna pick a day at VAM and we're all gonna see each other. All right, because we just need just find ways to cohese come together a bit more? Oh, really? Should we just be doing our spring meeting at VAM? Anyone have any thoughts on that? Of us doing our spring meeting at VAM instead of a separate meeting?
I think that gets really hard. I mean,
It is. There's only
VAM
so
really
many
difficult
allowed.
right then.
Yeah, there's only so many allowed. You have to get it in with LECA. I do have a regional meeting this year, VQI at VAM, so it does get tough with scheduling. But no, if you'd like to, just let LECA know in advance. But yeah, we have those. We don't mind at all.
I have like seven meeting. I have 7 meetings during VAM, so it'll be hard to add another one. No way. No way, Jose.
Sounds like a no. Sounds like a no. No way, Jose. All right, so I'm gonna scratch that off. But we're gonna see each other, so
Yes, I like that.
Drink or something, milkshake, whatever. Okay, so yes, doctors, just please keep your ears perked for that. As we talked about, next meeting in Winchester, we'll get you a date as soon as possible.
The question is hybrid, in person.
I want to do in person. Does anybody feel strongly that we should be remote or hybrid for the next meeting? Because Winchester is very central.
Hybrid, I think, will be also, just in case. I think every meeting now will have this hybrid option. You know, you never know what will happen. So I think we should keep our like option open. Definitely in favor in person, but I think like not to take the hybrid yet. This is my feeling, personal feeling. It's not like.
I mean, my energy to drive the distance and have like 40 people on computer and 5 in person will be limited. So I really think we should stress it's in person, and if you absolutely cannot come, you can call in, but it's not going to be easy to set up a hybrid room for everyone. That's the only thing. Like you could already see it's difficult here. Yeah, I don't know. Is there anybody else that wants to make a comment about it?
I definitely want everyone to come.
Chris says she definitely wants everyone to come to Winchester.
In person.
In person. She wants to see all your faces.
Together like a little tourist package and maybe golf and all that kind of stuff.
Oh, she'll get golf arrangements for you, she's saying. She's really gonna sweeten the pot here. So again, I would just stress that people should be coming in person, and they can call in, but it needs to be, if it's, as long as pandemic allows, we should try to be in person if possible. It's like 2.5 hours from West Virginia. It's right in the middle. Good spot. So that's that. Dr. Marib, do you have any? Do you have any comments?
Regarding the in-person hybrid issue?
No, about our meeting as our associate director of the VQI.
No, so just, so I love, we're seeing more and more regions trying to do regional quality projects, and I think that's fantastic. I think that's really, because from one center pursuing a quality charter is great, but there's power in numbers. And I think that's a nice way to try and get the needle moved faster, is by getting a lot of people, a lot of centers together. So I think that is a great way to go. I am always impressed by how collaborative the Virginia's group is, by the, pretty clear commitment from everybody that attends to actually make quality a bigger and bigger part of day-to-day life. So that's it.
Are there any other regions, because you've been going to a lot of the meetings, any other regions that are doing anything with supervised exercise therapy or any other quality projects that are happening?
So quality projects, there are a bunch across the board. So at least one region is looking at some DEI issues within their population. Another one is looking at, you know, for why they are an outlier for one of the modules, but not for a related module. So I think that there's a really wide variety of what regions are looking at. And and I think that those kinds of questions are what will help guide, you know, each of our modules gets updated on a schedule. And so the nice thing about the regionalized quality, I think that's more likely to then make its way into registry revisions than just single sites. Even when they show a fantastic result from their charter, again, there's power in numbers. So
I think even if we could have our abstractors adding to their PBI section about whether or not the patient had exercise therapy.
Yeah, and exercise therapy is really, there are several people that have long talked about, researched, tried to educate others on its benefits. And I know one of the holdups is the fact that it's not reimbursed well at all. So yes, it's reimbursed, but the reimbursement is awful. So it actually is a money loser for most large centers that try to engage in it. I have not seen anything in North Carolina basically saying that, oh, you're not going to be paid if they didn't engage in this or what have you. But I mean, we see that, you know, for some venous things, but we haven't seen that for PVI as yet. But other than the SET app from SVS, I haven't seen any sort of large vascular societal moves to really incorporate more SET. So I'll be honest, I'm a long-term believer in it, and it's nice to see. I wish it were compensated better by the government and by insurers, because I think that would be a good way to get more traction on it.
Absolutely. All right. I think that's kind of everything that we have from our end. I know Betsy has one more slide to go through. So does anybody else have any other comments on the meeting? We're gonna give you back an hour of your lives. We just have one more slide.
Yes, don't
hold on. Stacy has something. Does she want to come up?
Just real quick, I was just gonna say we can do any of these as a hashtag project too, and that's something that doesn't capture in.
Sorry, I'm gonna make her come up.
Can you hear me?
Can anybody hear her? No. Okay.
Any of these projects that we're talking about, we could do them as a hashtag project. If it's not something that's already captured in VQI, then that would make it easier to capture through the region.
Trying to make it bigger. Without further ado, here are the 3-star, 2-star, and 1-star. Can everybody see the screen?
Yep.
Okay. So I want to congratulate everybody. 3-star, I will probably not say your name right, so I'm so sorry. 3 stars are Carillion Roanoke Memorial Hospital, Centara Careplex Hospital, Centara Norfolk General Hospital, Centara Northern Virginia Medical Center, Centara Princess Anne Hospital, United Hospital Center, West Virginia University Hospital, and Winchester Medical Center. 2 stars are Charleston Area Medical Center, Inova Alexandria Hospital, Inova Fair Oaks Hospital, Inova Fairfax Hospital, Inova Loudon Hospital, Inova Mount Vernon Hospital, Centara Lee Hospital, Centara Martha Jefferson, Centara, is it OBC? Okay, hospital, thank you. Centara RMH Medical Center, Centara Virginia Beach General Hospital, Centara Williamsburg Regional Medical Center, University of Virginia Health System. 1 star is Camden Clark Medical Center and VCU Health System Authority. So congratulations to all of you for your hard work and dedication. So thank you. Give everybody a round of applause. So thank you so much. Thank you, thank you, thank you. Any closing remarks, Dr. Mintz, Dr. Musa?
Thank you for nice engaging meeting. Betsy did a great job. and we appreciate you coming on board. And I hate you coming on board, and I'm taken off board. But I really like, we appreciate the momentum, the energy. I hope Samantha all the best time to come, and I will be always available. Anything I can do to help. VQI is not position; it's something we live with, and we strive to measure what we do for a living, and to take it as an indicator for quality for our outcomes. And I appreciate also the great discussion we had this morning, Darren, you and I. And definitely, like, I see where you're coming from when we all need to meet in person. We all getting Zoom fatigue, and I think we'll have it more interactive to have it in person. Just post-COVID, I think not only our center, but many other center, we overburdened with work and obligations and not able to get the time off. And when we get time off, we have to dedicate it for a big meeting like SVS or some kind of related to residency or fellowship or anything like this. But I hope you guys all the best. I'll not take more time than this, and thank you and all the best.
I wanted to mention, so Alvear is, we want to thank him for his co-medical director position for the last 3 years. He has elected to step down for the next 3 years, but is going to still be very involved whether he wants to or not. We'll really appreciate all his involvement. Over the next 3 years, we do have a new regional RAC chair. So Dr. Klaus has passed that on to Dr. Farvar. And so we'll be in touch with him. He just had a baby, so congratulations. And we're looking forward to working with him for the next 3 years. And so over the next 3 years, I will be acting as medical director, but we'll certainly be looking for someone to come on as an associate medical director that could potentially transition in the future into that position. So if there's any excited young physicians or older physicians that want to get involved with VQI, that would be an excellent position to do that with. So thank you everyone for coming that came down, everybody who's on there. And if you want to talk further, have any questions, please contact us. And thank you to Betsy for coming all the way.
Absolutely. So don't forget, make sure you have your full name, and Jen is going to put into the chat box the CME link. So make sure you complete that within 7 days, and we'll make sure all of you have the correct link also. All right, thank you everyone for joining us on this Thursday afternoon. So take care, drive safe, and thank you all for being in the room today.
Thank you.
Thank you.
Bye.